Hello again, and welcome to Confronting the Complex. This is Dr. Jamie Kunkle. I'm joined by Dr. Janell Payne, per the usual. How are you doing today, Janelle?
I'm good. Still good.
Still good?
I know we were just lamenting about our long days. Long
Yes,
days.
we were. This is
Yeah.
being done on a Monday night, so you get to see what we're all like on a Monday night.
When
Uh,
we're punchy after our probably the longest day of the week, right? And
yeah,
like fielding all the phone calls and everything, messages from the weekend. And yes, so this isn't the quite refreshed night of sleep, fresh cup of coffee you get on Friday morning. And this isn't chill Sunday as we've been working in the yard. This is like I'm exhausted. I think I've peed 5 times, and that's my only exercise today.
yeah,
And
probably the case.
yes,
So
I
you get
know.
to hear
There
us
you go.
talk about mycotoxin testing. So we just did a segment the same day. That's why you can see the background's the same. Still in California,
Shirt's the same.
still hanging out. So we're going to talk about mycotoxin testing now. We just talked about tick-borne testing, Lyme testing, whatever you want to call it. Now we're going to talk about its close pal, mold, because there are a lot of similarities in terms of the testing isn't that great. It is kind of an elephant in the room sometimes that we do need to still consider. So we want to like try to do testing. We want to try to get the right, sometimes indoor environmental professionals when we're talking about environmental issues in one's home. We try to be very delicate about all those things. It's an important story. Yeah, I mean, you would agree with me, would you not, Janelle? Mold's important. What do you think?
Ugh. I got to tell you, when I first started practicing, I was a mold denier. Not that I was a denier. I knew that mold provoked a lot of symptoms. I didn't like it then, and now I dislike it more after I've delved into it more and I've embraced it more and I appreciate it more. I like it even less. And there is not probably a sector of medicine that is more nuanced and nebulous in testing that, anyway, there you go. Happy Monday evening.
Yeah. So
That's
let's
the real talk, the real talk
the
about
real
mold.
talk's gonna happen. It's unfiltered.
It's
So
unfiltered.
so let's talk about the types of testing that there are for mycotoxins first of all. So
Mhm.
mycotoxins being the metabolites of mold that are toxic and probably bad for you and your immune system, and some of them are neurotoxins, some of them are carcinogens.
I don't mean to interrupt you, but you make a really good point because a lot of patients they confuse mold from the mycotoxins. And Neil Nathan used the analogy of the gun and the bullet. And while some people may not appreciate the analogy, I think it really speaks to the accuracy of that. If mold is the gun, mold is inherently not that toxic, right? Just the actual mold.
Yeah.
But the mycotoxins, like you said, those metabolites are the bullet. That's what harms people are the mycotoxins. It's not the actual mold. So when we talk about disturbing the mold, treating the mold, all that. Anyway, all
Yeah,
right, carry on.
totally. Yeah, because
Sorry.
there's this sort of perception that mold is going to automatically infect you too. And although there can be colonization that comes from mold itself, it's still the toxins and the metabolites that are going to be the biggest problem most of the time.
Right.
Very rarely people are getting invasive aspergillosis, pneumonitis, or something, like some kind of like pneumonia from an aspergillus, the farmer's lung or something like that. It's not
Yeah,
like a thing
right.
so much. So you can't really always think about mold from the same context as infection. There's a time to use antifungals, although that's controversial in some fields, but it's different. So whether mold's alive or dead, it can be a problem if those mycotoxins are still around and they're very tiny. They're teeny tiny. I think they're like less than zero point 0.2 microns or something. They're like really, really small.
Really small.
So if you're getting exposed to them, still breathing them in, or they're still around you, whether you had a remediation or not, they could still be a problem. And a lot of patients become really sensitized to these things, and they can be directly affecting the immune system. They can be suppressing immune system function. It's no wonder that you might see mold with other perceived syndromes like other chronic
Yes.
infections or post-COVID in some cases, or long COVID or whatever, or
How
any.
often do you how often do you see mold associated with your patient's chronic illness?
It's common to see some environmental influence, and I'd say depending on where you are, once again, regionally, as I sort of mentioned on the previous podcast about
Right.
Lyme and stuff, mold's going to be a bigger issue in some cases. But Mold is because we all live in indoor spaces and somewhat enclosed spaces, and we have water flowing through those spaces and probably water coming out of the sky and everything like that.
We hope.
Sometimes, maybe coming from below, there's a chance that mold can be a part of almost any case. And so that kind of makes it difficult to be like, okay, well, when is mold not in consideration? More so is the question. It's almost like it's always in consideration,
Right,
but you have to kind of do the proper screening and figure out if it's something that's worth pursuing, I think, in terms of figuring out. But also, if they've been treated a bunch of times and they don't get better or they really can't tolerate treatment, sometimes, and they have other signs and symptoms that look like environmental illness, which we might get into, you may think that yeah they harbor these infections, but this environmental issue might actually be a bigger trigger to their inflammatory response. So
right,
fairly common is the answer. I
right.
often think of it. Yeah.
I agree. I totally agree with you. And I think it's important for people out there to hear that, like, this, we're going to talk about the testing, and then we will totally go into like nuances of treatment and all
Yeah.
that, like in subsequent episodes, because
Sure.
mold is too big. It really should be a mold series.
Yeah, you could have a whole mold podcast. It's just nothing but
You
talking about
know,
mold.
right, right. All mold, all
Mold till
things
we get
mold.
old. Yeah, it's it's just all mold all the time.
Yeah,
Uh,
yeah.
yeah.
But for the sake of this, we're just going over some of the most common testing and the nuances of it. And I'm just curious. All right, let's jump in. What
Yeah,
do
let's
you?
go for it. So I mentioned the mycotoxins are a big problem. So
Yeah,
there are tests to measure mycotoxins. There are tests that measure quote unquote free mycotoxins unbound to any carrier proteins or any neutralizing elements within our system. And then there's total mycotoxins in the urine, so to speak. The biggest controversy about mycotoxins generally in terms of testing is that for one, a lot of the original research was in like livestock and sort of granaries that were contaminated with mold, that have been
okay,
sitting in spaces and getting moisture and all that kind of thing, and that some of these things as a result can get into our food supply, and that when we're measuring these things, there's many mycotoxins out there that could just be from the food that we're eating. And then it's like, well, is that always a problem then? Well, it's hard to say. If you just ate that food and it was coming out in the urine, it might look high, but that doesn't necessarily mean that your total tissue burden or your overall body burden is ridiculously high. So there's certain
right.
toxins like ochratoxin, ochratoxin A or whatever, that's an example of a limited evaluation. But then there's other toxins, the way I see it, and you may see it differently too, but like stuff like black mold or Stachybotrys does not necessarily get into our food as much. It's not necessarily as much of a food contaminant. So if you see the quote unquote, the trichothecenes, it's always a fun word, trichothecene group, and all those mycotoxins, you might be like, that's a little more suspicious, isn't it now? And so, it really just depends. And then where are they in their process? Are they being exposed right now? Are they, post remediation? Are they in like detox mode? Are they 3 years out from like a remediation and a detox plan? Why are there still mycotoxins in there? Why? It feels like an ending river of
Yes,
mycotoxins.
yes.
There's so much to consider. I think that, you really have to take mycotoxin testing with a grain of salt. Like, don't ever rely on it. In my opinion, you don't rely on it solely outside of maybe screening, looking for those trichothecenes in the Stachybotrys black mold. What's your opinion on that, though? Because I'd say I don't put a lot of weight into mycotoxins overall.
I don't put a lot of weight into mycotoxins overall either, and for a lot of reasons, and some that you mentioned. But like, let's say we do a urine test on a patient, and it comes back with nothing, clean. Well, it could be a couple of things. It could be that you're number one, you're not exposed. Fantastic, good for you. Case closed. Or it could be that you're not detoxifying. Okay. So
Yeah.
like, and that's usually more the case than not being exposed in my clinical observation. Right. And so mycotoxin testing can be that. Secondly, if you test positive for mycotoxins, right? Like the flip side of that coin is you could be exposed and excreting just fine, right? Just like we are designed to
Right.
do, expose and excrete, like with no problem, no hiccups at all. Your body's just naturally getting rid of whatever you're exposed to. Or it could be that you're exposed and excreting and it's too much and you have hiccups in the detoxification system. So I find limited usefulness in it. I do it sometimes to try to capture, to try to get some clinical idea. But at the end of the day, I find myself now talking patients out of it more than I'm talking them into it.
Yeah,
So,
that's fair. And I mean, there are ways. You have to ask yourself if you need to really do this or if it makes sense. But there are ways you could like provoke if you were like not sure.
right,
You could do the glutathione or something or whatever, do a sauna in there, and like you could try to sort of get more of it out of the tissues. But there's always still that question that remains: is that, like you said, normal excretion? Is that normal removal? And is that really causing the illness? So
right.
it's kind of a tough one. And so mycotoxin testing might hold value, but not alone. Like it might hold value in like a bigger picture sort of thing, but I don't think I would ever use it by itself. That would be my opinion. So
Agreed. That would be my
what would
opinion.
be sort of the next way in which you would start to think about screening? Where would
I
you go?
I typically look at immunoglobulins. So I look at IgG. I used to use the LabCorp one all the time,
Oh yeah.
right? And
Uh-huh.
and it was kind of like I don't want to call it down and dirty, but it was pretty reasonably priced.
Yeah.
Either insurance covered it, and if they didn't, then I just went through my LabCorp account and paid cash. But I quit doing that because it's way too problematic, right? It's a pain to have to reimburse and collect
Yeah.
payment on all those, right? And like have to then later on bill. It took up too much clinical time. So now I pretty much exclusively use either my myco labs or real time labs. And those are
Yeah.
my go-tos. How about
Yeah.
you?
Yeah, pretty much. I mean, the same. Yeah, I've used antibodies more so. And to be clear, the MyMyco, especially, is the real time the same? They're antibodies to the mycotoxins, and so they're not just antibodies to the full mold species, like the IgGs in the LabCorp would be
Yes.
to the full mold, species. So
Yes.
there you have that differentiation once again, is it the mold or the mycotoxin? So folks can have sensitivities to mold, but if they don't have a high mycotoxin burden theoretically, or they're not having an overwhelming inflammatory response, they may not see those IgGs and IgEs in the cases in my
Right.
myco. And as the theory goes, the high IgEs might be more significant sometimes in terms of acute or inflammatory response around mycotoxins themselves. So you may be able to discern that to some degree. It's not perfect, but it gives you a
None
little
of
more
it's
insight
perfect.
into how the immune system is at least responding to it, if it's sort of seeing it as a major threat or not, which is suggesting there might be higher amounts of it, or there's a bigger inflammatory reaction. It's just that same story once again, is how is the immune system responding to this stuff?
And I don't usually see a frank allergy to molds. So people will tell you, I have an allergy to molds. Well, you don't really have an IgE response to molds mostly. And now sometimes they do. Like I have patients that go to an allergist, they get an IgG test, and they do have an IgE response to molds. And
Yep.
that is more definitive. And that's definitely on that allergic picture. I think what I see more so clinically is a hypersensitivity,
Yeah.
uh, is that immune provocation, MCAS, right? Like
Mhm.
patients that are diagnosed with multiple, not multiple chemical sensitivity, although that too, but mast cell activation, like those patients tend to often have mold as a driver in
Yeah,
there.
totally. Yeah, because I mean, it's one thing to kind of have like a sniffly, red eyes, conjunctivitis or
Right.
rhinitis kind of things in the face. Yeah, and to have like mast cell disorders or some sort of like
Right.
bigger inflammatory response, or what they call SIRS in the other world, chronic inflammatory response syndrome, and what that ends up looking like, all these multiple triggering of the immune system all over the place. And so yeah, those are different things. So they can have elements of IgE reaction, they can have elements of mast cell reactions, they can have elements of lymphocyte dysregulation and activation, autoimmune, just directly cellular toxic in various different ways, neurotoxic, what have you. There's 1,000 different ways in which these can manifest, but it's still important to differentiate: is it the mold that's causing some of the reaction, or is it the mycotoxin?
Right.
And as I said, there's a third scenario though too, that in some cases you could have a colonization with the mold, and that mold could be inside of your sinuses, or your airways, or maybe even presumably in your gut, although we don't have an easy way to measure that. and that they could be still producing mycotoxins metabolically, even if they're just colonizers. They're not deep infection agents. So yeah, how do you approach that? Like, how do you screen for that? Colonization, is that a thing? I don't know.
I mean, I have used the microbiology DX,
Oh, the nasal swabs, yeah,
nasal swabs.
that's a
I
good
do
one.
that. Otherwise, I don't really have a great method for detecting whether or not it's colonized. One thing you could do, and like I just got off the phone with a patient today, and we were just discussing this very caveat, is that the my myco labs or the real-time labs, if the numbers go up, if the antibodies go up after you've treated it, to me it does suggest that there could be some colonization. I might see that immune provocation go up,
Yeah.
but it's nuanced, right? It doesn't necessarily mean that. How do you do it?
Yeah, I mean, I'll if they have a lot of sinus nasal symptoms or otherwise, I'll certainly check for evidence there. And you could do a nares like short swab, or you can do a high nasal swab. You can do a microgen, which is like a next generation sequencing, and sometimes you'll find fungal elements in that way. And most often with the swab, you're going to find like a penicillium or something like that. It's going to be some sort of minor mold, but like a common mold. Doesn't necessarily equate to colonization. Well, if you treat it and their symptoms improve immensely, especially their sinus and their head symptoms, it probably is some level of colonization. And the treatments can vary. It doesn't have to be antifungals. It can be, rinses. It can be, natural antimicrobial agents or other things like this.
Right.
And then there's the presence of the staph marcons and the microbiology DX, which is supposed to be another marker of the person's been in a water damaged building or has been exposed. I'd say, yeah, it's not a perfect world, especially if there is stuff in the gut. I mean, I know some of your patients probably feel better sometimes whenever you do treat their gut with antifungals when
For
they've
sure.
been mold exposed, assuming you've probably gotten them out of the mold. And we do have to talk about environmental testing a little bit because that even though we're not IUPs and we're environmental professionals, it's still important. But yeah, you've probably seen some benefits, treatment in both the sinuses and the gut, huh? Yeah.
Oh, for sure. Yeah. I
Yeah.
mean, patients usually, but it's, I'm also really cautious because I've seen some of the most horrendous reactions by treating the sinuses too soon in
Yeah.
patients, especially if they have a lot of, number one, a heavy body burden, or they're really hypersensitized to the mold.
Yeah.
Like, we have to understand this is a direct passage to the brain, right? So causing that brain inflammation in some of my really sensitive patients, I'm really cautious in that.
Yeah, that makes sense. That might be where we start with some rinsing or, some flushing through.
That's exactly. I like we do neti pots first, right?
Yeah.
Like a neti rinse, or we do the xylitol sprays, right?
Yeah,
We do
something really
something like
gentle, some sil like a little bit of silver, like a little bit of
yes,
silver.
a little bit
Not
of
nothing
silver.
too aggressive. Yeah,
Yeah,
that's usually a better way to go about it when it begins. But the biggest question I always have, of course, is like, is the person still being exposed to mold, and how much mold are they being exposed to? And I think that that's one of the hardest questions to answer without the help. I mean, you can't do it without the help of an indoor professional of some sort that you really
right,
trust. And I'm not just talking about folks that come to the house and do air testing and then leave and tell you that everybody has mold. You know, grow up or whatever, or like just
right.
suck
Deal
it
with it.
up, buttercup, like whatever they say,
Right.
because they're suddenly becoming medical professionals. It's like we can't become indoor professionals as much as they can't become medical professionals.
Well, I'm really lucky here. We have a couple of really good professionals locally that really kind of understand the nuances of mold illness, right? And so they're really good. Even if they don't detect mold, they understand that their test isn't the end all be all,
Yeah,
right? Well,
that's
so
important.
it's
That's
it's really
important.
important. Yeah. So what do you use to test somebody's home?
Well, so if I'm just kind of screening them and I'm not going to be doing like the deeper part of the analysis, I'm going to say let's do a home dust test or an ERMI, an
Ermi. Yep.
environmental readiness mold index. And probably use one of the DIY, like do it yourself type companies that don't cost a lot of money, and do the areas of the house that are most suspicious. And you can combine them too. Like you could do the bedroom and the bathroom if it's like an attached, suite or something like that. But do an area, at least one sample in an area that makes sense. And then with that, we can just see one, if the numbers are high, but then which molds are also in their direct environment. And of
Right.
course, there's way more nuance to it. Like we didn't, check the outside with the inside. We didn't do like a differentiating, multi-test pathways or some crazy, where we do this part of the house compared to this part of the house compared to try and narrow it down. That's what the indoor environmental professionals do. But
Yes.
if I'd like to just sort of screen what's in their direct environment, that's one of the easiest ways to get some data and then to see if that adds up, or you can cross-reference that with any of your other testing or any other clinical suspicions. And occasionally people will be like, there's no way I have mold. This house isn't that old, 2 years old.
Well, I've seen
It
brand
doesn't
new
matter.
houses with mold. Brand new.
Doesn't matter how old your house is. I'm sorry to say, it just doesn't. Mold can grow within 24 to 48 hours easily in the right conditions. It has to do with have
Yes.
the right conditions been met to grow mold, because mold is everywhere, as some of those contractors say. It's true, it is everywhere. It's all outside your house and it's inside your house, but has it seeded, has it grown, is dependent on the conditions in the home. So it could be a water leak, of course, is the obvious thing. It could be any kind of water infiltration, but sometimes it's defects in the building too, and you don't know that. That's a hard one. So yeah, mold can be kind of scary in that regard, kind of
It
making
is.
your home not feel super secure. But I will just test people, especially if they have a complex chronic illness that hasn't been resolved by the five other doctors and nobody's looked at mold. It's probably a good reason to start doing some screening there.
I
Yeah.
agree. And what's really fascinating is if I have the privilege of spending patients' money like that, I will often ask them to do an ERMI test. And I usually ask them to swab multiple areas. Because I tell them the whole point of an ERMI test isn't to find out what area in your home is moldy,
Yeah.
but because if you have central air, you have mold everywhere.
That's it. Yeah.
But like, so I have them do their home or their work or their cars or their, right, like wherever they spend the bulk of their time, or highly suspicious, right, in that environment. And then I used to run, like I said, I used to run that LabCorp IgG all the time. And I would actually love to compare the two. And it's shocking. It's not a total side by side comparison, but it's shocking how much of a comparison it does make. So you can compare the antibodies with the elevated titers, mycotoxins in the air, and it's amazing. I mean, I've actually seen a lot of correlation that's matched up.
Yeah, totally. No, I think it's a good screener, and I suppose you could try to take it further with like the Hurts Me and some of the, Shoemaker things, if like how many points, but that's once again for all the
Again,
IEPs
yes.
out there. You let the professionals kind of handle that
And
stuff.
the nuts and bolts of the ERMI versus the hurts me, like patients are like, well, my score's not so bad. And I'll tell you, like, the hardest scores that are the ones when they come back like a 4 to 7, right? Those
Yeah,
are the hardest because it's like, well, but if you're really hypersensitive to mold, this could be really bad for you, right?
right.
And so the realities of it is maybe that house is bad for you, maybe that daycare is bad for your kid, maybe that car is bad to drive,
It's
but at the
totally
same time,
individual, and I think that's the hardest part of this
yes,
is what's
it's
safe for
so
one may not be safe for another. And there are those proverbial canaries in the coal mine that may alert the home, may alert the family structure even that there is something going on in the home. And it might be one member of a six-member family that has symptoms. The other people may not have obvious symptoms. If they get out of the house finally or remediate, they may actually be like, you know what, maybe something was happening. I just didn't really
Mhm.
realize it. I felt a
Right.
little more tired than usual, and my sinuses were more congested. Like it could be like easy things like that, that just sort of get better. But more often than not, the person that's in front of us, or in front of me, because I see a lot of complex illnesses, are the canaries in the coal mine. So they're the folks that, yeah, 4 to 7 on the hurts me. That's going to be a problem for some of those people. So like, how do you navigate that? Well, that goes with strategizing once again. But it's important. Like, there's so many different ways to take care of the problem. But the first step, oftentimes with these cases, is to figure out what's the probability that there is a problem. What's the probability there's a problem that we need to address, that we need to take care of here? Like, and how can we start to strategize on doing that? Because that's
And
really
it's not
the short of it.
right. And it's not simply a round of binders and glutathione that is going to clear that up.
No.
Like the problem can be it can you can have mycotoxins that are persistent, that stay for a very long time, and maybe they're hard to get out, maybe we just don't detox them well. And like Neil Nathan will say, there's a subset of the population, what, 25%, that doesn't make antibodies to detoxify these molds, right? So even having low antibody numbers, like sometimes I look at that and go, maybe you don't make antibodies to them, maybe you're not complexing with these molds to excrete them, right?
Right.
So it is. Did I mention I hate testing and treating mold. Like
It was implied.
it was implied. You got the hint? Okay.
Yeah.
I mean, there's all these nuances. So like when people are looking for something, and I always feel bad because people are like, I need to know. Like, well, I can't give you definitives. Now there are some patients that we know. They walk into Fred Meyer and they nearly pass out, right? Like, and
Right.
they know.
Thrift stores.
They know.
Yeah.
What'd you say? Thrift stores.
Thrift
Oh,
stores.
libraries.
Oh,
Oh, right.
yeah. Just
My
like,
very first mold patient was a librarian. And I was like, oh, like it was a tip off. Like when she told me, like, this is again, way back when I was a mold denier. And and she was like, oh, I just, like I was a librarian and I had to file for disability. And I was like, oh, 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 I think I know, and it took a bit, right? It took a bit. Um,
yeah.
yeah.
I know. I have to say, like, I tried very shortly to not pay much attention to mold, but it was not easy to do because I mean, my I told this story on a different podcast probably, but I was exposed to mold and my wife developed like an autoimmune condition when she was pregnant with our first child, and that was, pretty early on, not like more than a year or two after I had graduated from school. And I had mentioned kind of how weak I felt our education was on the nuances of mold and environmental illness. We got like a whole, dump of data on stuff, but like never really given the ropes because I don't think anybody really had a that was teaching there really understood how to do it. Just, it is what it is. Because I think that we've had to learn the hard way, and we've had really good teachers, I think, to a degree on how to operate within these systems. But it's
Right.
not like even now to this day, having the training that we've had and the experiences that we've had, that there is just some sort of like perfect algorithm here with mold. At least that's kind of how I feel about it.
I agree.
But I was, yeah. So I've seen mold injury in my household. I've seen the reality of it. I've been the person who's like, I just feel a little fatigued and maybe my sinuses are congested. I've been that person, and like I could probably handle it to a certain degree. Although now it's not the case. If I walk into a moldy building, I can tell like very clearly because I've done so much work to mitigate it in my environment. And it is true, the more you stay out of it, just the same way you stop using your fabric softener, as soon as you catch a whiff of somebody using that fabric softener, you're gonna notice, hey, what the
Notice.
heck is up with that fabric softener? And why?
I couldn't agree more. Our family has also had some mold illness, and I mean, because you've walked us through part of that journey. But we've certainly been exposed to it. I remember going back to a house that we were renting out, and we were doing some repairs on it, and I had the whole family with me, and this is when my kids were little. So of course we didn't have our beds in that house, right? So we go to this house, we pitch our tent, we put out our sleeping bags, and we all decide to sleep downstairs. Well, all of a sudden, the rest of us are ready to go to sleep, and my one child is like, her eyes swell shut and she's sneezing. And I was like, okay. And everybody pick up your things, and upstairs we go. And we slept upstairs on the carpet instead of downstairs on the carpet. Now, anyone who knows anything about anything is going like, oh, but your sleeping bags touched it. Yeah, they did. I know that now, right? Like, I know that now. I didn't know that then. Our pillows touched it, right? Like, and sometimes you can contaminate surfaces, right? So, and that's a huge problem when you have patients that go from one moldy house to another. Oh, and have you seen this? Here's a nuance for you, and I'm kind of being a squirrel brain right now. Here's a nuance for you though, that when patients sell one home and they go to buy another home, they tend to pick a moldy home. It's like the comfortable old shoe. I'm like, are molds putting off pheromones for you?
It makes you
Like,
wonder,
it
what
makes
is
you
it?
wonder,
What is
right?
it
Like,
about the mold? I mean, it's like I said, I still liken it to the dang fabric softener. Why do people continue to use that stuff? It's like I'm such a fabric softener hater. But it's kind of the same idea. It is interesting how people are sort of drawn to these situations, and it does become a challenge. And maybe it is that they're just like that sensitized to it. But then I have to also wonder, mold is just insidious. It's like you don't know always the history of the homes that you're buying. It's not like people are disclosing it all the time. I mean, they're supposed to, but it doesn't mean they're
Right.
disclosing it. But if you do a really thorough inspection in a new home, you're going to see a lot of times evidence of some kind of water damage at some point. I found evidence of mold in almost every one of my homes that I've ever bought. And as weird as it sounds, I've owned probably, let's see, one, two, three, four. I've owned like four homes, which is crazy to think about.
Yeah.
But of those four homes, like interestingly, the 100-year-old farmhouse. That's why I said don't discriminate because the house is old. Sometimes the old houses were built better than the new
Yeah.
houses. The new houses are built like Egyptian mummy tombs. A lot of times they're enclosed, for energy efficiency, but they don't breathe. And I have a guy like come to my house and tell me that your house doesn't need to breathe. That's BS. I'm like, "Eee." As I said, the conditions need to be met. So my very first house was the least moldy house. All I had to do was take out carpets and it was cool. And it's because it was built to breathe. It was a 100-year-old farmhouse in Washington State in a floodplain. And weirdly enough, it was the least moldy of houses. My
Right.
second house was in Vermont, and it just had a river flowing through the basement, which was completely normal in Vermont. That's cool. Yeah, cool. I guess conditions
And
need to be
horrifying. And horrifying.
met. Yeah, a little bit, a little bit, I must say. And then my
Mhm.
third house was a house that they were renting, so it had a bunch of like crazy tenants that would drive Jeeps through the yard and do all kinds of weird things, and so. There was mold in the kitchen, there was mold in the bathroom, there was mold pretty much in the roof and the eaves and like everything. So yeah, so I've seen it. And then even my current place, crawl space, but everything else was pretty cool. But I found stuff, how to clear out my crawl space. It's like if you look, you'll find it. So it's kind
If
of
you
just
look,
a question of like, are you sensitive to it or is it causing problems? It's probably not helping you though. I mean, if you can clean up your environment, certainly take it seriously. If you just want to think of like a health wellness perspective, just less toxins in my life. There's associations with, Alzheimer's, dementia, and like neuroinflammatory degenerative conditions. It's not a
absolutely.
bad idea to take it seriously, even if you're not clearly having reactions to it. A little bit of a
And something I
tangent.
tell patients all the time is that molds are immunosuppressive, right?
Yeah,
Like
yeah,
we use Cellcept, which is a mycophenolic acid. Like it's a mold derivative, right?
right.
It's essentially a mycotoxin that we give
Yep,
to patients so that they don't reject their organs on organ transplant, right?
right.
We give them an immunosuppressive. And so we have to even conventionally appreciate how immunosuppressive some of these molds can be. So when we talk about like why are patients more susceptible to some of these chronic infections now more than ever before, it could be their exposures. It could be these mold exposures that are kind of that crux that are making them more sensitive. So,
Totally. And it's a concept of toxic burden too, which we'll get to, I'm sure, at some point, and
right.
just piling up of things. Because we just have too many things piling up on our systems, which
Yes, we do.
as a result, unfortunately, we're losing some semblance of resilience because it's a classic story. Of course, you could say, well, mold's been around for as long as humans have been around, and we've probably been exposed to mold. Maybe we're living in moldy caves or whatever. But maybe
Right.
we also didn't have toxin A, B, C, D, and E that was, from industrialized society, or, maybe we didn't have, COVID and spike protein illness or whatever the heck,
Right.
and
And I
maybe,
think I'm glad that you mentioned COVID because in my patients that had either the vaccine or acute COVID, I have seen an instant hypersensitization to molds.
yeah,
It was
there's,
like overnight,
yeah,
like they weren't sensitive to molds and then they were. And the only thing that changed was an illness. And so
yeah,
it's just that dysregulated immune response. And I do tell people because how many times have you had the husband and wife in your office and there's tension? There's a lot of tension because the wife is sick or the husband is sick, vice versa. Occasionally it's the opposite. And the other spouse doesn't want to spend the money, doesn't want to move, doesn't want to, like, they don't see it as a legitimate illness, right?
right.
And I see that a lot. It's a really tense moment. And I do appreciate that we can't be dumping 70 grand into a remodel, of which if the remodeling company doesn't do it right, it'll make it worse.
Yeah.
Right. So I do appreciate those nuances a lot for I'm using that word
Oh
a
yeah.
lot.
Yeah, I mean there's a lot of nuance to it. There's a lot of there's a lot of difficulties along the way, and we can only really do our best to try to help folks navigate them and do it in the most ethical way possible.
Right,
And to
right.
assure that they're being set up with the most ethical indoor professionals. I try to get relationships with these professionals so I know them and so I trust them and so I know that they're knowledgeable and that they're giving their best measure of what's appropriate for that person, by probability, what's the best course of action for these people given the circumstances. And so if we can just all, because yeah, I've heard the term, mold is gold. It's true. Mold is gold for some people that take advantage of the fear and the fear
I've
mongering.
never heard that saying.
It is true. It's a thing, but it's not the most
Oh,
common in my experience. But it may be, like I said, I surround myself with folks that actually are more empathetic or more, at the very least, they're sympathetic.
right.
I think they are
I've
more.
never heard that mold is gold. That's kind of a dirty.
It's
That's kind
kind
of
of
a
a dirty thing, but it's I think it's just a slur to the mold industry by folks that are in denial more than anything. I think it's a
yeah,
sense that like, okay, well, any kind of building project is going to be expensive. So it's not that like mold is an exception to any other building project you're going to do, whether you're going to add on to your house or whether you're going to build a garage or whatever in the back. It's just that like the amount that needs to be done with mold is different from person to person and
right.
it's different from situation to situation. So how much they need to remediate, how deep they need to go into it is dependent on how sensitive they are and what is actually going on, what's going on structurally with the home. What if there's a structural deficit or something like that?
Exactly.
So there's just 1,000 variables in how and why mold remediation can become expensive, but it's a real thing. I can assure you of
It's a
that.
real thing. And, then there's also that conversation like, well, we can't put them in a bubble, right? There's mold everywhere. They're going to be exposed to mold everywhere. But I guess the argument that I try to make in favor of these patients that are really suffering with this is that if you're in a mold toxic environment, if you can get yourself into a less mold toxic
That's
environment,
right.
not mold free, less mold, or
Yes.
maybe a different variety of molds that you're not as hypersensitive to, right?
Yeah.
So if you can get yourself into an environment that you can heal, then you can also go back into these other environments and withstand them to some degree, right? When
Yeah,
you're
you
not,
have to figure out a way to kind of achieve the desensitization and the detox if appropriate. So there is such a strategy as mitigation, and
right,
there is such a term as sanctuary even within a home structure. Some of the IEPs use that term if they've sort of been able to differentiate what parts of the home are most contaminated. Of
right,
course, you can try to close off those areas. It would be convenient if it was somewhere that was like off in the corner of the home that you could somehow, cut it off even from the HVAC and whatever else, and then do cleaning in the other parts of the home, and then put your air purifiers in and do all that kind of stuff. So there are theoretical ways to mitigate. And I think mitigation is a reasonable first line strategy for some of these folks because oftentimes it's a good test. Like some people need complete removable, but some people just need marginalization once again. Maybe complete removal is not possible. Maybe the bubble, the clean room, all the things we want to do. Although I've had people go to the trouble sometimes of trying to create as much of that clean space as possible. And in some cases, I had this boy who did incredibly well with it, who was had the mast cell disorders, hypermobility, EDS spectrum, really, kind of a constitution that wouldn't sometimes doesn't do well with these things,
right.
improved by like 80 or 90% just simply by
Mm.
doing the remediation alone. And that didn't involve, throwing a bunch of whatever at this person that it may have otherwise been necessary as far as multiple medications, prescriptions, and various other things. So sometimes you
Right.
can prevent a lifetime of turmoil, especially with the younger population here, going to the trouble to either do the mitigation or do the proper remediation. So it seems really expensive, but there's like it's that classic story is like, what's the price on health? If you can demonstrate, determine, and prove on some level that it's helpful for that individual, it's just, you got to do what you got to do sometimes. It's tough.
So tell me, like, as we kind of wrap this up, tell me what you do, like, as far as, let's say you've identified mold, you really feel like mold is a part of this person's picture, you're treating the mold. Do you retest those antibodies or the urine mycotoxin tests or like, how do you know when you're done treating it?
Oh, it's a good question. I think most of the time, if I have somebody who's really sensitive, I might do some follow-up testing. I don't always do it at like the every 3 to 6 months intervals that people sometimes
Okay.
will recommend with mycotoxins, for example. But
I don't
most
knock that, but I also don't do that.
Yeah, no, exactly. There's probably some value in it. Like I said, monitoring the trichothecenes, possibly stuff like that. The black mold toxins, I think, are of value. But beyond that, I would say what I usually would be looking for is clearly symptomatic improvement, clearly stabilization in elements that I believe are related to mold. A lot of times, like neuroinflammatory stuff or neurologic stuff, seems to be a big piece, but it can be more than just that. But I'm just saying, usually there's some sense that there is just more overall stabilization in their regulation. So that's the other thing too. It's like, yes, you can run all those tests, but it's like the proof is usually in their response more than anything. The response
Right.
is really what you're looking for. And then to me, if it's like, okay, well, I peeled off a layer. I got you about 40, let's just say 40% better by taking you out of mold. Okay, well, now maybe we can
Right.
deal with those infections easier. Like maybe we should go reevaluate your infections and go deal with that. you know? And I feel feel way better doing that, having done that work with mold and improved them by 40%, because now I'm not going to tox them like crazy and their immune system is going to operate a little bit more normally whenever I go and treat the infections a little more if I have to treat them more aggressively.
Do you
So
tend to have an order? Do you like to treat mold first, then the infections, or like, do you have an order?
yeah, it depends on where the person is, arriving and what's going on. Sometimes the infections are really unstable. And you don't always know about the mold right away. I mean, you could say, oh, I'm going to do my diligence. I'm going to do all the screening. I'm going to do all the whatever before I ever even touch those infections. But some people arrive to you very much infected. I don't
Infected.
know. So
Yeah. Symptomatic? Yes. That
symptomatic.
would be my story. I mean, I walked in and like I know that my Lyme doctor was like, "Oh my gosh, you are so sick," And so she like threw the book at me, like all the things. And I was totally in a moldy environment. And she totally didn't even touch mold, right? She didn't even touch it. And I got my brain back, I got my body back, I got my life back. And then
Yeah.
I was still in a moldy. Now, was that a recipe for like relapse? Sure, right? I just happened to have moved, right? Like a year later. So that was fortunate on my part but that wasn't planned, we happened to move, right? Out of
Yeah.
circumstances. Um, but at the same time, like mold went largely ignored. It wasn't until afterwards that I kind of evaluated that whole scenario and I was like, oh my gosh, I was scrubbing mold off the walls,
Right.
right? I mean,
Right.
I was scrubbing it. And I remember thinking to myself, mold schmold.
Right.
Well, mold schmold got me. So
Yeah.
mold had the last laugh there.
I know. I mean, that's the thing is
Yeah.
that it's not that people haven't gotten away with ignoring mold in some ways, like with their treatments or with their process, but it doesn't mean it wasn't affecting them in some way or that it couldn't be. And what I see more often, especially this day and age, because I do think the times have changed a little bit too. It seems like there was a time, I know, there was a time when things seemed so much simpler that you could sort of just hone in on one of these elements.
There
And
was.
you could just treat them and then they would get
Yes.
better.
There,
But as it stands,
you're
you
not
have to
wrong.
look at these different layers. And if the treatment's looking slippery, like they're making some progress. Oh, I identified the three Bs, the Babesia, Bartonella, and it's getting better with treatment. But now they're like backsliding horribly, and it's like you have to think at some point, is the treatment appropriate for this person? Do I need to be more aggressive with the treatment, or do I need to really understand what else is going on in that person's terrain, in their environment? You have to kind of consider that. I think it's inconvenient
Yes.
sometimes because you want a kind of linear process, but the linearity of these things is just not the reality that I see most of the time.
And I totally agree, but I have to think that like I would call myself a pretty tough person, pretty stoic as far as my symptoms go. And I'm certain that if my Lyme doctor knew the degree that I was herxing through treatment, like everything that I added and how much I suffered, she probably would have had me stop. Right. But
Well,
I just
that's
assumed,
fair. There's a
I mean,
fairness there.
I persevered
Yeah.
because I was like, number one, I didn't know any better. I read just enough on the internet, which had just enough information to tell me that herxing happens. So I was like, you know what? We are forging ahead. And I did. But I probably, had I been on the other side of that as the Lyme doctor now, I'd be like, you should pause that. You should pause that. And I'm so glad I didn't. Like I just kind of burrowed through and came
There's
out
always that
at
question
light at the end of my
too.
tunnel.
Is there a right or wrong way to do anything? I mean, like I think a lot of folks are the right way is the way that works at the end of the day. There's a lot of folks that have a lot
Exactly.
of dogma in terms of like you got to do this before you do this, or you do this or don't do this because if you do this, it'll be like this,
Right.
and everybody wants a simplistic worldview on all of these complex issues because we all do. We all want to have a very simple paradigm of thinking. We want to be able to operate within that, predict outcomes, not harm the patient in the process. I mean, there's a lot of kinds of stuff we want, but that's all just ideal. That's all idealism. It's like just all like where we really would like the world to be, but it's not
Yes.
really how the world usually is. And so um, sometimes. Sometimes if there's a nail, it needs a hammer. Like,
Right. And I was given 4 hammers, and I took all 4 of my hammers and barfed every night and had a rash on my body and had chest pains and I mean, and could barely see for a few days, a few weeks. I guess it was a few weeks. I couldn't really see, like I went blind in my left eye. Like I had a lot of issues and now I'm like, oh my gosh. Like if my patients called me with that, I'd be like, stop right now.
right. No, I mean,
No.
most of us would probably be like, you not sure about that.
Yeah.
I'm not sure if
Yeah.
that's the
That's
best
intense.
direction
You
for
should
you.
stop. But I was like, there's a path forward, I'm going forward. Yeah.
Yeah, and I mean, I think there's something to be said for that. I think Herxes and die-off are their own sort of game, and I think we might have to talk about that at some point too again and kind of get into more detail.
Yeah.
What's a true Herx and what's like a pseudo Herx. And Herx really
Yeah.
was like assigned to really Borrelia burgdorferi primarily. So then you have like, that entity, the Jerisch-Herxheimer reaction. Then you have like this die-off stuff. And then it's like, how do you know some of that isn't like this toxicity thing that we're talking about too, or this,
I think
mast
it
cell
was.
thing? It's probably was or is, in a lot of
I'm
these
sure it was.
cases. And so
Well,
we just know more now too. And it's like, so maybe as a result, we go a little bit easier on people. Like they always say, treat the patient, don't treat the
right.
bug kind of
Yes.
thing.
And this was
So,
16 years ago. And I
right.
so appreciate like that you say that because at the end, like I, it might have been the wrong choice for me to just
Yeah,
push forward through that, right? And we can cause more harm than good in doing that.
yeah,
And patients should not take this as liberty to push through things that
right.
are really uncomfortable, right? Like it worked out for me because I think mine really was a combination of herx and toxicity, and somehow it worked out in the wash. And at the end of the day, it varies for everybody, right?
It
That could have
is.
been a
Yeah.
very
I
different
don't
scenario.
think it's that predictable. I think that's the thing is like you could say, oh, just push through it, power through it, come out the other end, but I've seen too many times where that approach doesn't work for people because
Right.
of course, and like I said, maybe my bias too is that I see people who that's failed. So
Yeah.
if I had seen more people that had gotten them better, I might have a different worldview. So it really
Yeah.
depends on your perspective. So
Sure
as
does.
long as we do understand that perspective.
But I've seen that cup of toxicity fill up to overflowing in these patients, and they just get worse. They don't have that classic Herxheimer response get better, Herx get better, right?
Right. It's supposed to
I
kind of be
might have
like
had
maybe
that.
an ebb and flow or something.
Yeah, mine was an ebb and flow and up and down, but my trajectory was mostly positive, right?
Yeah.
Obviously, mostly positive because I went from non-functional to quite functional in, a short amount of time, or a relatively short amount of time. But yeah, no, I appreciate you putting that out there. That's not necessarily the norm, nor should we expect that. And patients shouldn't persevere just because I did, because it might have been foolish.
Yeah.
And we
Yeah.
know things then.
Yeah, right. And I mean, and there's a time and it's between that individual and their care team and their doctor and everything too. Like there's no wrong way or right way. The way, like I said, the right way is the way that works. So as long as it works at the end, the journey can be really arduous sometimes, and we'd like it to be this, sunshines and rainbows and linearity, as I mentioned. I'd like it to be like this beautiful sort of upswing, but more often than not, it's got this sort of bumpiness to it, and you hope that the plot of the line is a linear line if you look at those little peaks and troughs. But you know,
Yeah.
it's not a perfect world. So,
Hey, on our next visit, what I would love to go over is some of the really interesting and scary symptoms that we've seen associated with mold toxicity.
ooh, yeah, we could do
'Cause I
that.
feel like that could be a whole episode of all itself. Like I've had some patients experience some really wild symptoms that one might not understand is actual mold toxicity.
Yeah, that's probably fair because we don't think of mold. Like I said, most of us in the society think of mold more as like an allergy and inconvenience at
Right,
at the worst. Not so much some of the really weird stuff that can happen from it.
right.
Like I won't get into stuff like Morgellons, but you know, there's
Yeah,
like
you want
there's some
to,
very
but you
bizarre
don't. Yeah,
manifestations that for a long time
yeah.
were not really well explained and considered to be like psychiatric. Like the
They
person's
still are.
crazy.
It's so sad. It's so sad. It,
Yeah, I mean they still are in some circles. Like I see people get labeled as such, but there's been more understanding that there are physical or physiologic elements to these things that they're not just made up. But so like mold gets associated with some of that weird stuff, and that's not only just a glimpse of it. So
yep.
so yeah, I'd love to go into more detail about the weird wild world there of mold because I think it's important for people to hear it and maybe have some validation if they're listening out there because you do feel like you're going crazy sometimes with these things. Mold is especially just like the other infections we've talked about, but mold especially does make you feel like you're going crazy sometimes, and for a variety of reasons.
Really bad.
It could be the gaslighting that you're getting from family members or from, some indoor professionals that aren't really professionals, or just the fact that like while you're in your home, you feel like just
Right?
pretty awful, anxious, or just out of your mind, or brain foggy beyond comprehension, or just you're not dissociation, whatever,
Dissociation.
derealization. All
Yeah.
these different things can come up with mold, and it's because of it's neurotoxins. A lot of these mycotoxins are neurotoxins, so you're going to see a lot of the neuro stuff, and it's not even just that. I mean, like I said, there's skin stuff, there's endocrine or hormonal
Seizures.
elements. I'm sorry.
Seizures.
Yeah, seizures. Yeah. I
Seizures.
mean, it's just a lot. So, yeah, we'll talk more about that later. But I think it's good to wrap up here for today with the mycotoxins and that discussion, the mold.
Okay, on that, I just want to say, can we have a whole episode on conversion disorder?
Oh, yeah.
Okay,
That would
because
be
that
cool.
ties in with this. And I want patients that have been diagnosed with conversion disorder, functional neurological disorder,
Yeah.
that's AKA a more politically correct way of saying conversion disorder.
Right.
Um, or like you talked about Morgellons. Like let's kind of have an offshoot of these things because they all deserve their special time.
Yeah, I would say so too, because these folks are definitely suffering on another level.
Unnecessarily.
That's hard to explain because conventionally it's just not something that's accepted or explainable. It's like it's just
Right.
kind of a matter of like we don't know what's wrong with you, and and the stigma that comes with that. You're also crazy.
Right.
There's just that piece of it. So yeah, those disorders are exceptionally challenging outside of like we don't understand what's wrong with you. There's also this labeling that happens in those cases.
Right.
So I think it's
So
important to give some airtime to that for sure.
yeah.
Yeah.
So for those of you suffering out there with those things, we will definitely delve into some of those conditions and let you know kind of what has worked for our patients, what we've
Yeah.
seen, and just to give you a little glimpse of positivity is that I've seen full resolution of those conditions.
Yeah, absolutely. Yeah, definitely. It is possible. So, well, thank you for joining us
Yeah,
today.
for sure.
This is Confronting the Complex. I'm Dr. Jamie
Thanks.
Kunkle. This is Dr. Janell Payne. Once again, we will,
And we're out.
yeah, we're out. See you next time. Have a good one. Goodbye.
We're out. You can
We're out
tell
of here.
it's what, 8:09?
It's
We're out.
8:09 on a Monday. We're done. See you
We're
next
done.
time. That's all you get from us today. I'm sorry. All right.
Let's go outside.
I'm not sorry. Goodbye. All right.
Bye.
Thank you for listening to our podcast, Confronting the Complex with Dr. Janelle Payne and Dr. Jamie Kunkle. As a reminder, the views, thoughts, and opinions expressed by Dr. Jamie Kunkle
are solely his own and do not reflect the views, policies, or positions of Gordon Medical Associates or its affiliates. Any content, discussions, or advice shared on this podcast are independent of Gordon Medical Associates and should not be interpreted as a representation of Gordon Medical Associates. Gordon Medical Associates does not endorse or take responsibility for any statements or viewpoints expressed in this podcast. Thank you, and I'll see you next time.